I am Dr. DeAun Nelson, a naturopathic physician practicing weight-independent healthcare. I invite medical professionals to listen as I discuss how shifting the focus off of weight in healthcare can greatly improve health outcomes for patients of all sizes. I will explore what it means to practice in a weight-inclusive paradigm and discuss tools to implement these ideas in practice. I was so excited to have had the opportunity to talk with Megrette Fletcher about diabetes this week. Megrette is a registered dietitian and certified diabetes educator who has worked in diabetes care since 1995. Her interest in mindful eating started in 1999 when she began meditating on a consistent basis. In 2005, she co-founded the Center for Mindful Eating, an international nonprofit organization that explores the benefits of mindfulness and health. In addition to offering webinar trainings about the scientific benefits of mindfulness and health, Megrette has written 5 books for professionals, including Diabetes Counseling and Educational Activities, helping clients without harping on weight. Megrette has recently created a Facebook group for health at every size professionals interested in diabetes care called Weight Neutral for Diabetes Care. Outside of work, Megrette is very active in the cycling community, a dog lover, passable cook, and terrible bowler. She is blessed to live and laugh with her family in beautiful New Hampshire. And without further ado, let's meet Megrette. I'm welcoming Megrette Fletcher to the podcast today. She is a registered dietitian and works specifically with diabetes, so we're going to be talking about that today. So Megrette, I just wanted to get a really quick background for you about, what got you into dietetics, and then also what got you into diabetes education, if you want to let us know that.
Sure.
Anything else you want to say too?
Oh, well, that's really nice. What a lovely invitation. So, my interest in nutrition starts with a sad story. So I wanted to be a physiological neuropsychologist. And so I wanted to study the brain after injury, so stroke or object injury. And the program that I was accepted into, when you're an undergrad, they had a PhD program, and you could go from undergrad right into PhD. And you had to be in the undergrad program. So they selected 8 of us to be in the undergrad program. And then for the PhD, it was 2. And then they basically said that if you wanted to apply outside, there weren't a lot, 35 years ago, there weren't a lot of these programs out there. If you wanted to apply outside, that typically they only took the next 2 people, and then anyone else who was below that probably wouldn't make the grade. So I was number 7 out of 8. So I got into the program, but I wasn't quite at that level that I was going to be selected for a PhD. And so my major advisor said, "What's plan B?" And I thought, well, I was thinking about being a dietitian. And he goes, "That's a great plan." So I went, okay. So it was, nothing like your junior year, the last semester your junior year in college, to turn around and say like, okay. So basically, because it was a health background, and it was like a kind of pseudo pre-med. Because of that, it allowed me to transfer over. And so then I had to go take all these nutrition classes. And then I was an avid skier when I was in college, high school and college. And last semester, my senior year, I had a traumatic injury skiing and had to drop out of college. And I remember explaining to these professors who were very nice, they knew me, they understood my situation, and they said, "It's okay. We'll let you kind of finish up your degree during the summer," when I wasn't in a hospital and I wasn't undergoing some surgeries. And I had to undergo about 4 surgeries after the skiing accident.
Oh, wow.
And so I got a degree in nutrition, not in dietetics, just a degree in nutrition. So just kind of the bare bones. And I remember my first job was working in WIC. And so that was women, infants, and children. And that job was not really where I wanted to be or what I wanted to do. I did love working in the community, and I still have an amazing regard for all of my Spanish-speaking family. I grew up in I grew up in a Portuguese community, and worked in a Hispanic speaking community for about 5 years. and then
Nice.
wound up going on and getting a degree in dietetics and then becoming a registered dietitian. So there was a gap in there, but I got a real taste of what it's like to work in the community and loved it. And then went back to school, got a graduate degree, and became a dietitian.
And what got you interested in diabetes specifically?
Another one of those circuitous routes. So I got done with my degree in dietetics, and I was always a little bit of a square peg in a round hole. Didn't quite fit in there. There's lots of reasons why that happened, but we'll just kind of let those go. And so my first job out of college was to work as a psychiatric dietitian. So again, the neurophysiology and the neuropsychology and the background in psychology was a perfect fit for me. I'd had all these counseling classes. I was very interested in psych. They're like, oh, you'd be perfect. You can work, in this psychiatric hospital. And so I worked in an eating disorder clinic. We had people for about 3 months at a time when I first started there. I would eat with them in the milieu, and we would do programming and classes. And I worked with the kids, and I worked with the adults, and I worked with the addiction center. And it was just kind of this like, oh, I love it. This is just kind of really using all my talents for good, not for evil. And I know. And then insurance changed, and that experience of being with somebody for 3 months was really reduced down to about 3 to 5 days. And my skills went to primarily tube feeding and giving people hyperalimentation, which to treat an eating disorder, again, I think necessary in some situations, but kind of ethically not really where I wanted to be. I got to sit back and do a little soul searching and say, well, what did I like about my job? And I loved the counseling. I loved the relationship. What did I not like about my job? So kind of doing that. So I decided to shift gears. I was working as a contractor for a health organization. And I said during an annual review, I think I'd really like to move into diabetes. I do a lot of diabetes counseling. And the next day, my kind of boss, the person that hired me as a contractor, she said, oh, I signed you up for a class so you could become a certified diabetes educator. I went, oh, when's that starting? She goes, oh, Monday. I'm like, it's Friday now. She's like, I know you wouldn't mind.
Like, thanks.
Okay. So boom, 25 years later, here I am. I've never regretted it. I've always loved everything about it. I love all of my patients. Many of my patients, I've been at the same facility for almost 20 years, and I've moved with them through a lot of life changes. Many of them say, well, you're just the same, only you have more gray hair. And when you see a picture of me, I have only gray hairs.
Yeah, you're like your own long-term study there.
I am.
Observational study anyway.
Oh my goodness. But I love what I do.
Oh, that's so great. And then to wrap to bring in the health at every size and the like the mindful eating and weight neutral approach, like how did that become a part of what you were doing? I mean, maybe you started out that way, but most people don't. So at some point there's like a point where we are introduced to it and start thinking, oh, hey, that's actually something that's really important. So kind of what was your moment where you kind of started figuring that out?
So I come from a family of people that live in larger bodies. So my family, all of them would meet the criteria for obese. And they're good people. And that is a conflict, within my childhood, which is I don't live in a larger body. And we've learned it's because I had hyperthyroidism. So I had some sort of weird, kind of medical problem. But it all makes sense that they probably all have more hypothyroidism, subclinical. And I am on the other end of the spectrum. So that piece of that dichotomy, and, just kind of looking at it and really recognizing that, you live with people that you love and that they eat healthy food, and, you know, that's a struggle for them. They're like, I eat less than you. Why? And everyone ate less than me, keep in mind. But
Right.
but um,
You're like, I will eat everything.
at times in my life, that was definitely a true statement. But they really would eat balanced meals and be a different size, and so I just came to accept that people come in all sizes and shapes, and that's not part of it. That's a big part of it. But I really want to give kind of credit to my sister, who really pointed out my thin privilege and said, you know what, sweetie, you're not that special because you're small. And it was really interesting for me when I remember recognizing thin privilege and kind of coming back from, I had an internship where I applied and they interviewed us. And the woman said, "Oh, you'd be perfect for the job because you're so pretty and you dress so well." And I thought, so the biochem didn't matter, that advanced degree that I'm working towards that has no relevance. and, and
Right.
so it works both ways, so I think when we talk about weight bias, it works both ways. And I witnessed it on one end and I experienced it on the other. And, just having people say things to me that were so full of weight bias, because of my, I had a health condition. I have something called hypercholesterol, familial hypocholesterolemia. So I think I was about,
Yeah.
maybe I might have been 22, and my cholesterol is 700, 1200. So my cholesterol is just like through the roof, crazy high. And I asked my mom about it, and she's like, "Oh, that's just how we are." And I guess she had it. I'm like, okay,
hmm
you know, but everyone would be like, "Oh, that can't be right because you're thin." I'm like,
Right.
dude. But again, it was back 30 years or more. And so they just didn't understand cholesterol like the way they did. But I remember having my health concerns not being heard because of my size. And
hmm
I'm like, I don't think this is a little problem. And, they just kind of minimized it. So I think for myself, when I was younger, my sister really, and my brother both really were very clear that I had thin privilege. They realized it, my family all realized it, and that's fine,
Right.
that's fine. But they wouldn't let me get away with it. And so I grew up recognizing that I had to accept who I was, and I, you know, was accepting who they were, and that's a spectrum. And so I think my childhood was just one of those things where you did recognize that health is behaviors, and it's really not what you weigh, and we have to focus in on just the behavioral piece of health, and really loving who we are and really accepting that.
hmm
And so that's where I think I was a square peg in a round hole, because when I was a dietitian, it really, when we went to nutrition classes, they unconsciously promoted a lot of thin privilege. And I don't think that they had too loving, or, siblings are great teachers. So, they didn't,
Yeah, they are.
they didn't have the siblings that I had to kind of beat it out of them. And I don't think that I could explain it because the whole health at every size movement wasn't around. And as I move forward in my journey around just nutrition and dietetics, I just kept getting very frustrated when people would talk about weight, because to me it was so irrelevant. And I was just like, it's not a conversation I'm interested in. And that was kind of how I just left it. It's just not a conversation I'm interested in.
Yeah, yeah, that's great. I mean, like, it sounds like you didn't have to go through what a lot of providers have to go through, and a lot of people have to go through in, trying to change the way that they're thinking when they move into health at every size, and move into weight independent care, and, like taking weight out of it. So that's awesome. I like your siblings already.
My siblings are great. I
uh,
really, I do have really wonderful siblings. I think the struggle that I
yeah,
have with the health at every size was, it wasn't around when I was kind of creating my own path. And so I went on the journey of mindfulness that made more sense to me. I kept getting really
yeah,
frustrated at people that kept talking about weight. I'm like, it is a futuristic behavior. Who cares? Like your weight and weight
right.
loss, that's in the future. I want to be in the present moment. People are like, oh, well, my weight this, my weight that. I'm like, that's in the past. I can't do anything about that. Like, I just really want to be present. And so my journey moved towards mindfulness and mindful eating, and that really coalesced with, when I discovered meditation and started meditating and just felt like healthcare was not particularly present. And that was a struggle for me.
Okay, so I'm going to do a little bit of a subject change now. We know a little bit more about you, and actually, that was very instructive too, to kind of have an idea of where you're coming from as we go in and start talking more about diabetes, and then the work that you do as well around diabetes and the weight independent way that you work with it. I tend to say weight independent instead of weight neutral because weight is not really neutral in our
Mm.
world, unfortunately, as you just described. But there is certainly it is certainly important in a lot of ways to take weight as a treatment, weight change as a treatment out of the picture and focus more on, like you said, behaviors, and then ultimately trying to help the world have a little less weight bias, but that's a long-term goal. So when we were talking, we talked a little bit about just some different ways that you educate providers, because you do some education for providers, and I'll post links and stuff to anything that you want to let people know about. And you sent me some material that was amazing on educating providers, and so I wanted to get into that a little bit because that's mainly the reason you're here. I'm very excited about it. And so I thought that maybe we could start with the 8 core
Sure.
defects with relation to diabetes. I know when I was looking at them, when you talked about it, when we talked a few weeks ago, I was like, oh, I don't really remember
Mhm.
learning it this way. And it's possible I did. I mean, school is a little bit of a blur sometimes. But when I was reading those, they made a lot of sense. So I kind of wanted to hear what you had to say about those and remind our audience about a little bit of the pathophysiology of diabetes.
Sure. Yeah. So speaking about diabetes, we are talking about type 2
Yes, thank you.
diabetes. And when we talk about the core defects, it's referring back to DeFronzo's work, which is based in 2010. And I think a lot of times, if you went to school and 2010, like I had a couple of kids by then. I mean, so many of us, turn around and say, "Oh, geez, that was a long time ago." Like, ooh.
Yeah.
So again, it may not be something that you're as familiar
Yeah,
with.
I think
But
I was already
DeFronzo.
halfway through school, I think, by then. So yeah, that
Mm,
might not even
mm, yeah,
really gotten into my curriculum as very much.
exactly. So it's not super new, but it's really not that
Hmm.
old. And he just identified that he calls it the ominous octet. And in the show notes, if we can just add in, there's a great graphic, and there's actually a couple of different training programs that are available to help people understand the ominous octet. But starting at the top of the slide, we really see a decrease in insulin production. So the beta cells and have declined in their ability to produce insulin, and it's estimated that at the time of diagnosis, it's a 50% reduction in insulin secretion.
Wow.
But we also I know, I like who got that. We also see that glucagon secretion is increased as well. And so that is, the liver will respond inappropriately. So we see that. And that's also through the alpha cells. So we see that glucagon is secreted. There's an increase in glucagon secretion. Incretins, which we know a lot about now, that gut hormone, we really find that they're not working as well. And so we have a decreased release of incretins. And when I studied diabetes, incretins wasn't even on the horizon. Like, I remember when they discovered them and they used to call it Similan.
Wow.
I know. People are like, what is that drug? I've never heard of it. I'm like, we used to tell people about it, and it like stuck to tubing. It's very complex. Okay. So we see a decrease in incretin. We also see an increase in lipolysis. And so again, when we start getting into fat metabolism, this is one of those things where it's part of diabetes, and we need insulin to metabolize fat, and that's part of a pathway which I can draw it out for you, but in a podcast, who really cares? We'll just know that it's right, lipolysis. Like, I had to look that up. So you're like, I could pass it on a multiple choice test. Yes, you could. So we also have increased glucose reabsorption by the kidney. We have a change in our neurotransmitters. So that sensation of feeling full, that has shifted with diabetes. And that's one of the things that people talk a little bit about. And in a book that I co-authored with Dr. Michelle May called Eat What You Love, Love What You Eat with Diabetes, we really talk about how listening and learning about physical body cues and how we recognize the physical experience of hunger and fullness really can help us kind of overcome some of those, because I think a lot of times we get hunger cues not only just from the weight of food in our stomach and not just from the change in blood sugars, but also I think a lot of people experience a cellular hunger. And so we can talk a little bit about that. There's a decrease in glucose uptake by the muscle cells, and the liver does overproduce glucose. So those are the 8 core defects, and there is a lovely little graphic. And then if we add to that maybe the 9th one, which is high blood sugars by themselves make the body resistant to insulin. So when we have high blood sugars, and we'll talk about the insulin knife, it is also part of a defect that affects blood glucose regulation.
Interesting. So it's like the body is holding on to glucose or trying to actually make more because there's like probably cell hunger, right? But
yeah, exactly.
But the insulin is not there, and the body's not making enough insulin either, or making too much, and then it's not working. So it's almost like it's fighting against itself. Like, I'm going to keep glucose, but I'm not using it, so now it's just hanging out.
Yeah, the analogy that I use when working with my clients, I talk about imagining that they are taking a tour and they're in Fort Knox. And they go, yeah. I go, so you're surrounded by millions of dollars. And they're like, I am. I go, yeah, any richer?
Nope.
And they go, no. I said, that's diabetes.
Yeah. I use a UPS analogy. Like the UPS guys are trying to get the glucose into the cells, knocking on the doors, but nobody's answering. Somebody's home, they're just not answering until finally enough packages have sort of piled up around, and finally somebody gets a little, a package or two in, but you have a lot of packages hanging out.
You do. So whether it's Fort Knox or UPS,
you're not getting what you
really
need.
Describe. Yeah, exactly. And that's really creating a whole cascading. There's just so many other factors that are happening. So once we understand what the defects are, we can understand kind of what the consequences are, whether it's not enough packages or we're still pretty poor when we're surrounded by glucose. So it is just a remarkably complex disease. And, as I shared before, I think the media has just done such a disservice for people with type 2 diabetes because they simplify it to the point of inaccuracy. It's just not accurately being portrayed in the public and in the media.
Agreed. I think there's a lot of, if you're just eating too much sugar, boom, you're going to get diabetes, which of course we know is not accurate. There's certainly people who eat tons of sugar and never get diabetes, and vice versa.
Or if you just lose 5 pounds,
Right.
if you just lost weight.
Right.
And that is like such a soapbox for me. I get so angry
Well, can we
that
actually?
if you
I'll let you get on that soapbox for a little bit because I do. I want to talk about weight and diabetes specifically because type 2 diabetics are often larger folks. And not to say that people who are smaller don't get it, but it is more common in larger folks. And of course, usually the number one treatment option is to lose weight, right? Outside of medication, and that, of course, does not always work. And so I kind of want you. I would love to hear your soapbox about weight and type 2 diabetes and how those two things interact.
Yeah, all right. Be prepared. Here it goes. So, using the guidelines, first of all, diabetes is not curable. So it's a chronic disease, and the definition of a chronic disease means that it isn't cured. So if I said to you, DeAun, if you could lose weight, or you said to me, "Oh, Megrette, if I lost 10 pounds, I wouldn't have diabetes." I'm like, no, you still would. If you lost weight, you'd still have to manage your diabetes, and that's it. And so there's this fantasy, there's this fiction that losing weight makes a chronic illness not chronic.
Right. And
And that's
even
not
I'm sorry, I didn't mean to interrupt, but even if your glucose is is in the normal range and manageable, you still have to manage it.
because, and we have study after study after study, that once the behaviors that allowed you to regulate your glucose stop happening, your glucose goes back up.
Mm-hmm.
And we have this from the DPP, and a 10-year, after the DPP trial, we have it from Look Ahead. We have it everywhere you see. You have to continue the behavior. So it's not about weight.
Right.
It is about behaviors. And the part that just gets me so frustrated is people are like, well, if I lost weight, if you lost weight, you still have to manage your diabetes. It doesn't stop.
What about weight loss surgery? I know even a lot of physicians will talk about, the quote unquote miracle cure of weight loss surgery because it really does drive down the glucose immediately prior to any weight loss. And I mean, I have a lot of thoughts on this, but you're the expert today. I feel like that's something that needs to be talked about as well a little bit.
Yeah. So, weight loss surgery, and I'm not an expert on weight loss surgery. And we do know that there's something about the physiology of bariatric surgery that changes glucose and how we regulate our body. And I've read a lot about this, and to the best of my understanding, and I know one of your listeners will have a better understanding than I will, and they'll be able to inform us all. But the blood sugars change within 48 hours post-op
Right.
of bariatric surgery, which tells us it's not weight. There's some other pathophysiology going on there, because if it was weight, they wouldn't improve. And so we really start having to, we've been so deluded and so misinformed about how weight is a surrogate marker for health, and it isn't. Weight is not a surrogate for health. And the biased information around health and health research that's so weight centric, it just skews the results. There's something going on here with bypass surgery, and we don't have a clue what it is at all. And when it comes to type 2 diabetes, and a lot of people will say, well, let's just do bypass surgery. Bypass surgery is a surgery. It's risky.
Yes.
And there are a lot of people that don't want to go through that. So that's not an option for them for lots of reasons. There's a lot of people that wouldn't be a good candidate for that surgery, period. And there are a lot of people that turn around and say, you know what? I'm okay the way I am. I like who I am. I don't want to change me. I've been me for a really long time, and I'm cool with being me. And that, to me, right away, you've identified 3 populations. We still have to manage them. We still have to help them with their type 2 diabetes. They get to get care.
Mm-hmm.
And putting out a solution that I think is probably maybe 2%, maybe 8% of the population, but a fraction of the population is interested in pursuing. What about the other 90%? What about them? How are we going to manage them? It's like everybody's favorite tool. I'm going to go pick a multiple $1,000 surgery that's going to have huge, huge impact, not only on you physically, but socially, mentally. There's so much that this surgery is going to touch and affect. And we cling to it like, I'm concerned.
Yeah. And, the thing that I think about is that if people are told that their diabetes is cured after getting bariatric surgery, they may be less likely to continue to do the behaviors that will keep their diabetes under control, because they still have it. It's still going to be an issue for their body ultimately, because really, even with changing the gut, the form of the gut of the GI system is going to change, ultimately those 8 core defects permanently.
You're bringing up a huge point, and I can't say hooray enough.
Yeah. And it's so important. So, we don't want people to say, oh, I got weight loss surgery, I lost all this weight, and now my glucose numbers are great. And now I'm never going to have to worry about it again, because, however many years down the line, they are going to have to worry about them again. And so spending the time learning those behaviors would have been way more helpful with or without the surgery.
Right. And there's that fantasy again that we can cure an incurable disease.
Mm-hmm. Yeah. And maybe someday we can, but we haven't figured that out yet.
Oh my goodness. I know. I will so be willing to get retrained as a dietitian. I'll do anything else, like find a cure for diabetes. I'm all aboard, please. I could go pursue another, path, another career path. I'm all in. But I just, again, I just really want to support and reiterate that comment about, bariatric surgery. If we sell it as a cure, it will actually become the downfall of all of our clients. You have to keep up the behaviors. And those are the behaviors for bariatric surgery. Those are the behaviors for diabetes. We have to care for ourselves. And that's, I think, at the fundamental, kind of core of why I am such a health at every size advocate, is because health at every size is saying, you're all by yourself. There's no judgment at all.
Yeah.
What are you going to do you're enough. Mm-hmm. So what do you do now? How are you going to care for yourselves? There's no one telling you should. What do you want to do?
Right. Right. I often think people want to lose weight because there is such thing as thin privilege. It is easier to live in the world in a smaller body. And that's just a fact, right? And so I absolutely understand the desire for people to be smaller. It is a reasonable thing. But I also feel like I always want to ask people, like, if that just wasn't possible, which it really isn't in the end, and you just let go of that, and the world also let go of that. So the world, we can make a more inclusive world for people of varying sizes, not just weight, but also height too. So that there's a lot of tall and short people who can't function very well. Then, would you be okay with your body? And what if there were things that you could do to make your body more livable, and the world more livable? And I often wonder how significantly that would change our health and how we look at health and how we look at size. If people were just able to be okay and able to function really effectively in the world, in the body they're in.
Right, right. And isn't that everyone's right?
Yeah, Yeah. And it is hard. And so like, when I talk to patients, they're like, I want to lose weight. I'm like, I get it. I get it. I get it. It's probably not going to happen and it's not going to be sustainable. So, I focus on trying to help them, change behaviors and do what they can. Because certainly what they can do is not all of the things that affect their health.
Right,
But
right. And
but it's important for them to do what they
yeah.
can to feel somewhat like they're taking care of their body.
And so kind of unpacking that concept of weight loss, when I hear clients say I want to lose weight, I switch in my mind and in my words. I hear it as I want to engage in self-care.
Mm-hmm.
And I think that
And
that's a
engage in the
huge difference.
world
Yeah.
beyond that,
Yeah.
right?
And I think though that again, health has been weight loss and energy restriction has become a surrogate for health.
Mm-hmm.
And it's so erroneous. It's just such an erroneous thought process, logic pathway. It's just wrong. And so when I have somebody come in and they're marinating in this diet culture that we live in, and they come in and they see me and they say, I've got diabetes, I've got type 2 diabetes, and I really need to lose weight. I think to myself, I've got type 2 diabetes, and we can delete the expletive that
Mm-hmm.
is actually not said, but it follows that sentence because,
Mm-hmm.
oh my gosh, what am I going to do now? Type 2 diabetes is genetic. So there's a high probability that they've had a mom or a dad or an aunt or an uncle or somebody, a brother or sister, sibling, whatever, somebody else is dealing with this disease. And there's a lot around disease and family culture and how we approach disease, particularly a chronic disease like this. But when you kind of let that shock go and we start saying to ourselves, okay, I have type 2 diabetes and I want to lose weight. I have type 2 diabetes and I want to take care of myself. And that's really the key. But we force weight loss onto our clients. And what winds up happening is they actually don't want to be told to lose weight. They really want help in managing their disease. And because society is so pushing this weight loss, what we find is people are actually not accessing their diabetes self-management training benefit that's available through Medicare. And
Yes.
that's criminal. It's just criminal. I
Yes.
have people come in, they say, I've had diabetes for 12 years. I've never seen an educator. And I'm like, oh gosh, why? Oh, well, I saw the educator and she told me if I lost, 5% of my body weight, I'd be cured. Oh gosh, I've never monitored my blood sugars. Oh gosh. Oh, I didn't really think I needed to take my medication every day. Oh gosh. And
Mm-hmm.
so we kind of come back. I think that this pressure and this fantasy around weight has really led us to not treat the patient with diabetes and educate them about diabetes because we spend all of our time, trying to sell them on weight loss, which is ridiculous, but it happens. And then when they say, I really don't want to lose weight, I really want to manage my diabetes, but I don't want to lose weight, no one knows what to do with them. They're like, well, who do I send them to? Who in the healthcare industry doesn't push weight loss?
Right. And so that's actually something I actually did want to talk about. That was kind of a good segue because we're trying to talk to providers. I feel like a lot of providers get really nervous because that's the only thing they're really taught is get the patient to lose weight. And certainly there are other things that we're taught, medications and ways of eating and things like that are helpful, but it's all with a weight loss focus. And so I'm afraid that a lot of providers, are maybe have been listening to us the last 40 minutes and thought, oh yeah, that makes sense. And, maybe that shouldn't be my first thing that I go to, but I don't know what else to do. Right. And so and I know that's like a huge topic. we can, if you're interested in coming back, we could maybe do a whole show on just treatments. And then you also teach providers how to manage. And I think I mentioned that at the beginning. So I'll put that in there too in the show notes. Do you have sort of a short-ish discussion about, or can we have a short discussion about what are some basic options, instead of just focusing on that weight loss? And maybe it's just a matter of changing your attitude, and just not going there first. Yeah. Do you have any suggestions to start there?
I think I do, actually, and I really appreciate you asking that question. So as providers, if we just turn around and ask ourselves a couple of questions about the whole piece about diabetes. So we're really talking about the whole person, and we really want to manage the whole client and the disease itself. So we do want a client to eat an energy balanced diet. And a lot of times they need training to understand what an energy balanced diet is about. So, I talked to this and I presented this to many providers, and they look at me and they go, well, isn't that a weight loss diet? And I go, no, it's energy balance. So it's the energy that a body needs at whatever size they're at, that's the amount of calories we want to provide. And so we don't want to provide an energy deficit, because we know that restriction causes binge eating. It's the greatest single predictor of binge eating. So if I say to you, and you need 3,000 calories, eat 1,800, it is going to set up a situation where you're going to binge.
Right.
And the predictability of that binge, I'm going to say right now, is about 98.9%. I can predict the binging, okay? Because restricting calories creates that dynamic to play out. So restriction,
right. And then,
go ahead.
I was just going to say, and then the binging also creates a lot of guilt and shame. That is also not helpful.
Which also triggers more binging. But more than anything, binging messes up blood sugars. That's it. So now we binged. We've been really good.
And now we're feeling guilty because we binged, and now our blood sugars are off.
And we feel terrible.
Everything's horrible.
Exactly. And that creates insulin resistance. And now we don't want to exercise. And now we don't want to take our meds. And I feel really guilty. And now I don't want to go to the healthcare doctor, because now I have to tell them that I'm binging. And, we just really have no good data on the frequency or how many people are experiencing binge eating disorder, or have a disordered, are in the disordered eating spectrum around type 2 diabetes. But again, my suspicion is it's high. And this is one of the things that we don't want to talk about. I don't want to go to my provider, learn that I have diabetes, and then be told, and then come back and say, hey, doc, the reason why my blood sugars aren't in target is because I'm binging.
Right.
That's not a conversation I wish to have. I know it's not a conversation my clients wish to have. It's the reality of what's happening now.
Right. And if you have somebody who's eating, like you said, an energy balanced diet, so they're getting enough calories for their body. And something I think people forget is, if you have a larger body, your body needs more fuel to function. It just on a regular basis.
Sure.
And so somebody, saying, I'm going to have 2,000 or 3,000 calories a day. If you're a large person and you're active, which hopefully you are, that's part of your treatment plan, right? Is to move your body as well. So then you also need, some extra calories to manage that as well. A lot of people may think, oh my gosh, 3,000 calories a day, that's just, But if you've got a very large body and you're moving and thinking and, doing all of the things that we do every day, 3,000 calories might be perfect.
Right. But the best part is that you're not obsessing about food.
Exactly. You're just like, I'm eating.
And your meds, your blood sugars are now stable. We can adjust your medication management so it's now stable. And you're able, in a place you're not obsessing, and you're like, what would it feel like to move my body in an enjoyable way? And you're with somebody who's supporting you to move your body in an enjoyable way. So whatever that is, maybe it's chair yoga, maybe it's walking, maybe it doesn't require spandex. So,
I think that's the quote.
Yeah. So, okay. What would that look like for you? And so we encourage people to move their bodies in an enjoyable way, and we ask them to do that in a consistent fashion. So now what have we done?
Mhm.
We're asking people to eat an energy balanced diet. I think we should also ask them to eat a nutrient dense energy balanced diet. So really work with
Mhm.
increasing the nutrient density of that energy balanced diet. I'm asking people to move in enjoyable ways on a regular and consistent basis. I am also going to toss in there, hey, let's check our blood sugars and see what's working. Let's give our
Right.
provider information so they can evaluate, is this treatment plan effective?
Right.
Okay. So now I want to talk about coping. I really want to talk about how are you coping with the disease of diabetes. And people will say to me, well, I'm not obsessing about food anymore, and I'm not feeling guilty about this restriction, binging shenanigans that I have been dealing with because I've always been told to live in a smaller body. And I'm moving my body in enjoyable ways. I'm discovering how my body feels. I'm talking about getting nutrients in. I talk about coping. When people are saying, you know what, in the past I coped with food, I go, oh, so you know what? Are you receptive to finding other ways to cope outside of food? And we bring in the mindfulness piece. We start recognizing that when
Mhm.
we're coping with food, we find blood sugars rise, we don't feel well. It's not
Mhm.
effective. It's effective to eat if
Right.
you're hungry. It's not effective to eat when you're not hungry. And we all do it. I do
Right.
it. You do it. Everybody on this planet eats when they're not hungry. And so we
Mhm.
recognize that how does that fit into my diabetes management? And how can I feel empowered to A, recognize that pattern, and B, to start seeing choices? What are my options?
Mhm.
Am I empowered enough to say to somebody, oh, that looks beautiful. Thank you so much for offering it to me. I'm not hungry.
Right.
Not,
And I feel like, oh, go ahead.
I'm
Go
on
ahead.
a diet. Or not,
Mhm.
I have type 2 diabetes. I can't, I put that in quotes, eat that.
Mhm. Yeah, I find that it's something that I also think of too is that the more restriction in not just like I'm not getting enough calories, but also mentally and emotionally restricting certain foods, saying like sugar is bad and I could never have it again, also leads to binging. Even if you're getting plenty of food, even if physically your body is fine, food is such an important part of our mental emotional lives and our social lives that sometimes even if you're diabetic, you want to have a piece of that pie that you love. And being able to find coping strategies around, like, okay, so if I'm going to have some of this, and I know it's going to affect my blood sugar, how do I manage that? Right. And so that being able to have things like pie, or I just was thinking of an experience I had with somebody recently who's type 2 diabetic and had like a third of this amazing pecan pie with a couple of us and ate more than he was anticipating, but then kind of was able to think, okay, so the rest of the day, like, how, what else kind of am I going to eat so that this isn't going to affect my glucose as much as it could. I feel like remembering that and not just saying, like, I can never have X again, or picking and choosing when you have things that are going to affect your blood sugar negatively is also, part of that coping skill, right? To be able to say, I'm not always coping with food anymore, but sometimes I do. Or, I'm not always eating, the simple sugars at, gatherings and parties, but sometimes I do.
Mhm.
Does that make sense?
Absolutely, and it really sounds like you're bringing in the an element of self-compassion, which is so important for
Mhm.
health. We need to be compassionate. Diabetes is a terrible disease. I mean, it sucks. It just sucks.
Yeah.
And when we try to say, but if only, Betty, just be with how crappy diabetes is. If you don't cry at least once in your life at the suffering that diabetes causes, you know, hang out with some of my friends, because they are
Mhm.
dealing with diabetes, and I have lots of people in my life that have type 2 and type 1 and all kinds of in betweens. And, they're all my heroes. And when I hear people say, if they only, or maybe they could, and I'm thinking, these people are just, they are managing an alligator. I mean, this thing is just one hairy, angry alligator. And you can't, unless you're wrestling with that, it's just not fair for us to tell them what to do. What is really awesome for this, though, is to support the positive health promoting behaviors that they're currently engaging in. And that's it. And that's just what you did.
Yeah.
You said, hey, you're making a choice to enjoy food. I support you to enjoy food. How can we manage, what else can we do to make this, not impact your health negatively? How can I support you in the choices that you made? And so many times in healthcare, the empowerment piece of listening and learning, well, what are you doing that's working? Just that skill of asking that question has huge, huge benefits for our clients. Many times they've never been asked, what are you doing that's effective? What are you doing that's working? How are you promoting health? What are the things that you feel are benefiting you? That is such an awesome open the door question.
Yeah. And, and I feel like that self-compassion too, and, having some flexibility allows for somebody to feel more in control, which is something I think a lot of times people don't feel about their health. And especially if you're diabetic, you start feeling out of control. And then also, I think it might help reduce diabetic burnout because it's exhausting. It's exhausting dealing with it every day, all the time, especially with type 1 diabetics who've been, having to deal with it since they were children usually. But even type 2 diabetics, to just be able to say, it's okay. I'm doing, all the things that I can to help my body, but that also includes helping my health, but that also includes helping my mind and my spiritual side, my emotional side, all of these things. And sometimes that doesn't look like the perfect diabetic control or glucose control. Not letting it perfect be the enemy of the good.
And
right?
perfect doesn't exist. And if anything, the continuous glucose monitors have told us, and we've learned, is that there is no such thing as perfect blood sugars. And even A1Cs that are 6.5, most of the time, they have blood sugars that are 300 and blood sugars that are 42. And so again, we cannot pretend that A, it's easy to regulate blood sugars, B, that there is a perfect blood sugars. The standards, we look at blood sugar management and say 50% of your blood sugars in target with reasonable, without a significant amount of hypoglycemia and excessive hyperglycemia, in the 400s, 50% of blood sugars in target typically means an A1C of 7. And if we can get it up to 75% of our blood sugars in target, usually it's less than 6.5. And these are obviously mathematical averages that can be skewed by highs and lows. But when we start looking at, what is the percent of blood sugars we expect to have in target, we're not looking at 100%. We're looking at somewhere between 50 and 75%. And when we have explainable lows and highs, that's really doesn't make us nervous. It's when we have unexplainable lows and highs, that's when we get very concerned.
Right. And I would imagine that even people with normal glucose who are non-diabetic have also this variation in glucose. Maybe not as drastic, but
everyone's
our bodies are meant to do that. Like, they're meant to handle things and bring our body, bring everything kind of back down to an average as much as possible.
Exactly. And we have these great counter-regulatory functions that people with type 2 diabetes and type 1 diabetes don't have. And so we recognize that, when our blood sugars start to go up, the pancreas does release, there's a phase 1 and a phase 2 release of insulin production. And also when our blood sugars go low, we release and secrete, glucagon, stored glucose from the liver. And that's our regulatory and counter-regulatory, effects of all of this. And there's lots of other hormones that are in play that we haven't even identified in this whole process. Right. So our ignorance around type 2 diabetes is, quite large. And that's one of the frustrations that I have, is that so many patients aren't getting the education about what type 2 diabetes is and how to manage it. And they're not getting the support. It's not getting communicated to the provider. And as a result, the provider, is missing out, because working with an educator, having a dietitian who can talk about an energy balanced diet, help people with their food and non-hunger coping. And those would be the Health at Every Size dietitians and nutritionists. Having them work with your patients with diabetes, first and foremost, if they are in part of a diabetes self-management training accredited program, they have 76% more time than you to do these assessments. They can be with a patient up to 13 hours in the first year of diagnosis. Can you imagine that?
It's so good.
It's so helpful. And when we look at all the studies that talk, and these weight-centered studies that talk about how weight loss, like the Look Ahead study, that study, very intensive, the intensive lifestyle group, in a 5-year period of time, they had 76 points of contact. When you think about that, seeing a patient 5 years in a 5-year period of time, talking with them 76 times, I think my clients would take out a restraining order, but that's just me.
And if the patients are willing to come in because they're not just being told to lose weight, and they don't feel bad about, just going in and being able to be able to talk in a way that's not shaming, then they will actually take advantage of all of those hours. And that would be
Wouldn't it be helpful? Right. And that way, the diabetes plan, which the educator or the dietitian or who's ever helping assist with the education writes up, tells the provider, hey, provider, this is how Bob, this is how Juan, this is how Susan is managing their diabetes. It's accurate and up to date. The provider just looks at it and goes, oh, this is great. I know how you're managing your diabetes. And, Juan and Susan and Bob go, yeah, it's really working out well. My blood sugars are X or my blood sugars are Y. And if it isn't working out well because the physician and the provider is evaluating the overall care, they'll say, well, I think we need to tweak your blood pressure. Oh, I think we might want to tweak your, diabetes medication. Maybe we want to adjust it down. Maybe we need to increase it. That's really what it's all about. So getting the education allows the provider to do what the provider is supposed to do, which is help the patient manage their overall health. And it's not getting stuck in this quagmire of, well, are you really taking your medicine? Are you really testing your blood sugars? Why aren't you testing your blood sugars? Well, what's really going on? I'm noticing that, and that all of those conversations bog down that 15-minute, that 30-minute appointment. So you leave feeling like you didn't do anything.
That is such a good point. And on that note, we're starting to run out of time. I mean, I think I could talk to you probably for hours, and I'm sure people would listen for hours. Well, maybe not for hours, but so I did want to mention that I think that you are going to be putting out a book soon that helps providers with this.
It is. So it's called, it's Diabetes Counseling and Education Activities. And really this book is how to teach diabetes without focusing on weight. And it's available. You can go to my website and follow the link. And if you're interested in going through some additional training, I offer both webinar-based training and also self-studies. And those are available for providers who are dietitians and other types of providers. And that's available through skellyskills.com.
Thank you very much. I appreciate your information.
Thank you so much for having me. It was a pleasure.
Thank you for joining us for today's episode. The theme music was composed and performed by Galen Davis.